facility is Medic 1. Medic 1 inbound to your facility, emergency traffic with a 45-year-old male in cardiac arrest. Following multiple gunshot wounds. CPR in progress, patient intubated, IO in place. We're with you in 5 minutes.
Welcome to the EMS Handoff Podcast, your source for all things EMS. Now let's welcome to the show your hosts, Bradley Dean and David Blevins.
David, thanks for the intro there. Sorry you're not able to join us tonight. I know your mom had a medical procedure and you're traveling back home, so please get home safely, and everybody will keep your mom in their thoughts and prayers as she recovers over the next few days. But tonight, we're joined by Janet Taylor, who graduated from nursing school in 1998 and worked in various departments throughout the hospital, gaining knowledge and experience in ICU, OB, ER. She's a certified emergency nurse, certified flight nurse, and has her certification as a critical care transport provider. She works full-time for Golden Valley Memorial EMS as a nurse medic, and she enjoys teaching part-time for EMS conferences across the country and for local paramedic programs. She also writes various modules for online forums and is regularly featured on EMS One. And you can see her where she'll be heading off to at the next conference at www.emsteacher.com. So Janet, tell us a little bit more about yourself, and we'll pick up and get started.
Thank you, Bradley, for that intro. I graduated from nursing school in 98. Like most people in EMS, fire, healthcare tend to have a bit of a short attention span. So I loved everything that I could get my hands on. I worked med surg for a little bit, but I got bored easily. I went to ICU, worked a little bit, and that's where I got all that experience, not realizing that well-rounded experience was going to bless me later on in my career. So I still work for Golden Valley as a nurse in a paramedic role on an ambulance. I'm still certified in emergency. I can still pick up a couple shifts here and there, but my passion is improving healthcare. And so I'm in education. I kind of dabble in education at work. I work with my department in getting out continuing education, CEUs, meeting standards, and then I've been teaching on the conference circuit for 14 years now. It's kind of surreal to look back and see where all I've been, who all I've met, how many times I've been blessed by meeting others out there. But I'm seeing a lot in education and how it has changed significantly over the last 4 years. And that's what we're going to talk about tonight is the new COVID medic concept of what we're having, with all these graduates from these programs.
Yeah, so let's talk about transitioning COVID medics into the real world, and kind of correcting the knowledge and skills gap that we're seeing, because anytime you've got a break in education that forces people to change modalities and how they learn, how people are taught, there's going to be an interruption, and there's going to be some lasting things from that. So you mentioned COVID medics. So what is the definition of a COVID medic or EMT?
I've heard that term, COVID medic, COVID EMT, since COVID. But if you Google it, at least when I did, I couldn't find a clear definition. No one's defined it yet. So my partner, Lori Sizer, and we work together quite a bit on some workshops and education stuff. We discussed this because she's in a different program in another part of the state, but we define COVID medic or an EMT as a graduate of the EMT or medic program whose traditional teaching format was interrupted or altered by the COVID pandemic being declared. And from there, their instructors, the whole program had to adjust and see how much information they could get to the learners and how many skills they could teach while usually doing it online. Because if you remember when that was declared, for the next 6 months, it was online everything. They tried to limit in-person contact. So these students were at a great disservice, especially if online isn't their learning format of choice. And so they came out with not as much confidence, for sure, and possibly not as much didactic learning, and definitely not enough skills and practice hands-on in real life and in scenarios in school that you would normally have. And so they walk out with their paramedic license, their EMT license, and they're hired because we're on a staffing shortage nationwide. And now they have either very little orientation or the amount of orientation that a non-COVID medic would have got, but that's not enough. And now they're being put out on trucks and saying, good luck, God bless, and we'll help you through this, hopefully, if they even heard that much. And that's just such a disservice to our new graduates. It's a disservice to us, their coworkers, directors, patients. It's a full spectrum of things that are lacking.
Yeah. So we had to take basically what we were doing and make an entire shift in just a really, really short time. So, we had a change of class format. So you had educators who were not familiar with online formats and how to completely go online that were forced to do it. You had students that had butts and seats that, they were like, well, I came to this traditional class because I didn't want to do the hybrid. I didn't want to do the online. Well, now they're forced to go online. And now, so we've got all of this stress being put on all these individuals and trying to make everything work. But not only, so a lot of people look at it and go, okay, yeah, so that was 2 years. The people that did that are now out. We've got new graduates coming out. We've got people back in classrooms. But what they're not looking at is those people that are now in classrooms, the 2 years prior to that, the 2 years prior to that, were doing online stuff in high school. And now I'm seeing issues with grammar. So documentation suffers. I'm seeing issues with math. Drug math suffers. Seeing issues with, basically just logical frameworks of basic concepts sometimes that people just don't understand. Exactly.
Yeah. And, I mentioned the online format being a learning tool, a learning format. We were taught eventually, I'm a visual learner, I'm an auditory learner, I'm a kinesthetic learner, and those things are all important. But now you've got I'm an online learner, or if you're older, I am not an online learner. And you've got to be able to recognize that as your personality because, I'm not an online learner, but I've taken online classes. I'm driven enough to where I push myself to go that extra mile to make sure that I understand it. But that's all self-driven. And some people don't have that drive. And so if they don't recognize that, that's an injustice. They've got to be able to reach out to somebody and say, listen, I'm doing the stuff. I need more, and so we refer them to Wolfram Alpha, YouTube, Khan Academy, anything like that. But you've got to have the drive. And, some people have it, some people don't.
Well, and unfortunately, there's some people who have attended a traditional classroom that didn't have the drive. And we can usually see those and either put in the right direction, or we can see those and, unfortunately, they are dismissed from the program.
Right.
But when we were transitioned to the online, we didn't have that face-to-face. We didn't have the direct interaction to redirect some of those individuals. And they barely got through with that minimum performance, that minimal line.
Yeah.
And,
and some of them were very happy with that. They passed, they're good. Exactly. And, I have that problem is even in an in-person situation, I don't always catch those social cues that tell me they're not getting it. There's no light bulb moment. So I frequently check in on the students, but online is even harder to do that. You don't get that energy. You don't get that feel like I don't think they've got it. Let me make sure and reach out to them. And you reach out by text or email and I'm like, how you doing? Are you struggling with it? I'm fine. Okay. So.
And I will never forget. And it was somewhere around 1999. Brian Cyphers at Davidson County Community College looked at me and said, hey, online education will be the wave of the future. He said, we either embrace it now
Mm-hmm.
or we fall on our face in 20 years.
Yeah.
He doesn't know how well, I mean, he knows now, but I mean, he didn't know
Yeah.
how right he would be.
Right.
So, I dabbled with it. I learned a few things and I was able to adapt and do a lot of stuff. But one of my counterparts, um, you know, Kelly Kirk, who runs 911 e-learning, he took that, when we met with Brian and he just ran with it. So,
Mhm.
the student selection that he had, they were prepared when everything was remote because they were already doing it. The only thing that they had to halt was, you know, meeting in person to do some of the skills.
Right.
And he was able to adapt technology to do that, which we'll talk about that in just a little bit. But, how did we get here and why do we allow minimal performance and not use more technology to our advantage? It was there
Mhm.
prior to 2019, 2020, but
Right.
why did we not use it?
Me personally, I am not a techie person.
Yeah.
I'm too old. I still like my pen and paper. I mean, you could give me all the technology in the world. I have no idea how to use it. And when I learn a software program like a charting program at work, I'm good once I learn it, but do not change it on me or I will have a meltdown. So with, a lot of EMS instructors tend to be a little bit older because, they've done their thing and they're transitioning into a less physically active job. So you've got that, the generation of EMT paramedic students are, young 20s. And now you've got your generation of typical EMS instructors. I know some really young ones, but truthfully, most of them are about my age and they're, in their 50s, 40s and 50s.
So, you know, when this shift occurred, like I said, some people were adapted and some people were ready,
Mm-hmm.
but a majority of our peers were not ready for it.
No. And it was overnight. It wasn't, hey, in the next 3 months, we're going to be doing this, this, this. It was starting tomorrow or possibly starting at the end of this week. We're going to have to do it this way from now on because of the pandemic being declared. And it was a quick switch. And, it's trying to get used to that, trying to build all your material into an online format, figuring out those things like how do we get skills across here? And how do we have an in-person, a real-time discussion on this topic that we're working on? Yeah, it was quick.
And, then we had to decide, was it going to be, synchronous learning? Was it going to be asynchronous learning? Okay.
Right.
So I've got 20 students online and I'm sitting in an office
Mm-hmm.
and limited interaction. Well, that's boring.
Yeah.
So it's hard to teach the same, 3 hours or 8 hours sitting behind a computer screen like we're doing now versus, being in a classroom.
Mm-hmm.
Well, so when you got 20 people, you've got to have a little bit of rules online or everybody's talking at once.
Right. And then you got the rules where, they must be up on a video so you can see that they're engaging. But then you got some people who are like this. And I had one person who's like, I'm listening to you, but he was out in the hammock in the backyard, just swinging away. I'm sure he did listen to me, but everyone else is like, well, that's kind of nice. It was kind of a distractor. It's the rules online, the etiquette online is still being figured out.
Society has really shifted between social media and online learning.
Yeah.
Because you're right. There are people who sit in a classroom, traditional lecture, sit there and they text or they're doing something else.
Sure.
If you've got Google, use it, challenge me. But to be texting your buddy across the table or in another classroom, they're not paying attention. People cannot. There are very few people who we can say really multitask. Everybody time slices.
Yeah. Oh, that's a good way of putting it. Yes.
Because you time slice, you answer this. You time slice, you're paying attention to what I'm doing. You time slice, you answer this person. Because if you're really engaged in responding, there's an emotion that goes with a response.
Mm-hmm.
Every time you text. So you have to separate yourself from one emotion to answer another emotion. So
Right.
that's why I say people have to time slice. They're not really multitasking.
Mm-hmm.
The loss of the in-person interactivity, how do you think that affected the learner?
They were isolated. I've heard that so many times, where some student will be struggling, and I'll be like, okay, did you reach out to your peers? Did you do this? Well, we're all online, and no one was online at that time, or no one answered my chat thing, for an hour. They're isolated. So they truly feel like it's all on them. So we tried to coordinate more chat group meetings, to kind of discuss that stuff, but then we go down rabbit holes, and it was quite a struggle for them to just feel that isolation.
So with that isolation, do you think that impacted people socially and psychologically?
Yes. Yeah. Mentally, anything in life, mentally, if you feel like you're the only one experiencing this, it's detrimental to some people. But when you start hearing people like, oh, I have that, or I have had that, or yes, I experienced this too. It's a sigh of relief. Like, I'm not the only one. But that wasn't being said in these online classes because everyone was doing their own thing. When they did get on chat, they'd talk. Some of them had the same problems. I can't understand this concept. But there were, let's say 20 students, 15 of them had a different problem, and we couldn't address all of them all at once. So we were trying to work together. It did help a little bit when students are like, oh, good, I'm glad I'm not the only one. That was said a lot, like, oh, I'm glad I'm not the only one speaking up. So I'm afraid of how many times they didn't speak up. And it's still an unanswered question for them 2 years later, 4 years later. Did they get the answer they needed? Did they finally get that light bulb moment with that concept they were wanting?
So not only were we forced to change and shift the classroom piece, let's talk about clinical rotation. Well, before we get to clinical rotation, let's talk about exams, because
Okay.
sometimes exams were suspended until they could figure out how to make sure people were not
Right.
cheating online.
Exactly.
So how are we to gauge the learner and the retention of material if we're suspending exams?
Mm-hmm. And then the exams that are suspended, they're stacking up. So now instead of having 2 tests that were due, now you've got 4 tests behind. And so you're like, what do I study first? Hopefully they've been studying the whole time throughout, but they're also so behind, like, okay, well, let me study this one first. So exams were a challenge. And you can only gauge how much the person has retained by an exam. What I felt like was the biggest problem was the clinicals you mentioned and the skills. I can see how somebody has got it if I see them work in a scenario in a lab or in real life on clinical time when they enter the area, the person's home, the ER, wherever. I can see if they've got it. They're comfortable with it. They just roll with it. They jump in, they do their assessment, they ask the proper questions, and they're just click, 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 doing it. We've all seen that student that doesn't get it. If you don't have clinicals, or if you're not doing skills and scenarios in person in a lab, you're not seeing that, and you're not seeing that gap. Because, even now that we have non-COVID medics, occasionally we'll get one coming through the clinical area, and I don't know them. They're not my student. But the first call we go on, I can say, oh, they don't have it. Or maybe, I'll pull them aside and say, okay, next time we're going to maybe do it a little bit this way. And I think that'll make me more comfortable. I have that because I'm with them and I can see them, and it's real time and I can feel their energy. Clinicals were awful. If they did any at all. I heard some programs just completely did away with their clinicals and did everything simulated online behind a computer screen. Kind of like, your online ACLS and online PALS now, which is okay. But the skills portion and, that's lacking. You mentioned that somebody figured out how to do skills online.
Yeah. So, as I mentioned, Kelly has done a lot of stuff.
Okay.
And so what he did was he worked with the educational institution, and so they got it set up where the students would come in. So basically, they come in, the lab is set up, all the equipment is there. They come in and they practice the skills. What they've got though is they got a big computer screen over here. There's an instructor that has the same mirrored equipment that performs the skill, walks the student through it. The student and the instructor then do it together. Then the instructor watches the student, and the student has the opportunity to practice. What he found was you had a little bit less downtime because you didn't have other people to talk to in the lab. They were more focused on the skills. They were more likely to practice it and perform it correctly under direct supervision of one-on-one. So it's almost having a one-on-one. The problem is now you drive up cost. So as you're driving up that cost, what's the number of students going to do? They're going to go down. So that's at a disadvantage.
Right.
So, and then they were able to work through it to do it basically where they're in two different rooms mirrored, with a computer in between so they can run the mannequin and do the other simulated stuff. Right. So yes, there was a virtual piece. There was still virtual, but real, which is possible. So they were able to do that. So, those students turned out, rather successful and did pretty good. But it's the other ones that I'm really worried about who did not have that same opportunity and interaction.
Yeah. One of the programs that is near me, they required like a dozen live intubations in the OR by this point in their program. And hospitals are like, no one's coming into this hospital. No students, no. So they're like, okay, well, we'll do it all by mannequin. And mannequins are great for getting that muscle memory going. But you also know in the back of your head, I can't kill this thing, And so we've got a few COVID medics who they've been out for 2 to 4 years. They've never intubated a live person and they're scared to. And I don't blame them. So, depending on your protocols, they may just go straight for an eye gel, and that's fine. But if your protocols say intubate first and use eye gel only if you can't intubate, that throws everything off. You don't have a definitive airway, and you're causing that medic to have less and less, confidence in their own self because they, again, were just said, hey, congratulations, you got a medic license, get on the truck.
Yeah. And I mean, yes, and we're seeing that. I mean, I still go out and I still run calls and had the opportunity the other day to respond to a call, and I get there and they're working with a patient, and the paramedic was like, hey, I've attempted to intubate twice. The eye gel is not sitting right. We've got good SATs, which is the bag mask. I said, we're good. You're effectively ventilating. You're effectively oxygenating. I said, I'll come around in a second and let's reevaluate where we are. And so we did a couple more things. And I was like, we got it sets up to 100. We bought ourselves some apnea time. I'll take a look. And I went in, intubated. He was like, how did you do that so easy? I'm like, I took my time and I prepared the patient before intubating. And I said, positioning's everything. And he goes, but it just made it look so smooth. I said, but there again, I said, I've been doing this for years.
Yeah.
You had limited opportunities. Because he's been a paramedic now for about 4 to 6 years. So he was right at the tail end, right at the very beginning of that.
Right.
So,
so do you feel like he was frustrated? I'm sorry?
No, I think he was frustrated just because, well, he didn't have the opportunity.
Right. Yeah. By your story, I feel like he might have also been frustrated that you got it so easy.
Well,
When is
a
he going
little
to
bit,
get to that point in his career?
but but at the same time, I was pleased to see later at the station they're practicing with the mannequin.
So he's one of ththose that has the drive. He's
Right.
not one we're going to be worried about.
No.
Yeah, for sure.
So, but the whole part of that is, if you miss it, it's okay.
Yeah.
You know, I, I don't know how many I have, botched or messed up in my career, and somebody else makes it look so easy.
Right.
But at the same time, when you're done, go back and practice. And if we go back and we look at research and a couple other things, when you pull that research, it says somewhere in there, on the average, it takes a minimum of 47 intubations to become competent.
Wow.
How many people got that in their paramedic class?
Pre or post.
Right.
Yeah, exactly.
So I was very fortunate in the 90s when I went to paramedic school to be able to do that.
Mm-hmm.
I don't think we have that opportunity now.
No, not at all.
So how can we fix or how can we work on better preparing or easing the anxiousness that some of the COVID medics have?
There's a lot of different theories. One is, as an educator in the department, take extra time with them when they're fresh out of school. Make sure that they are comfortable with concepts, with skills, with putting it all together, critical thinking. But also, as an educator, we don't have time. Education is only maybe about 10% of my job at my job. I still run on the truck full time. So it's catching that person between calls. It's catching that person when they're at work and maybe you're getting off, seeing if you can catch some time. The other thing, a lot of places, they don't have that opportunity. They're just like, here's the stuff. If you want to practice, you can. But you mentioned positioning. That paramedic didn't know how to position. And there's nobody there to tell them, hey, everything is right as far as your muscle memory and as far as your form, but that patient is not in the position. You haven't prepped that patient properly. There's nobody there to correct them. So there's that self-driven part, but then there's also the responsibility on the agencies to identify those gaps. And I mentioned Lori Sizer. She and I have worked together quite a bit. We are working to be released in 2025 on some type of a program to decrease that knowledge gap, whether it's going to be all didactic or all skills or a combination of both. Not sure. It's still kind of in the works, but we're only going to be able to hit those people who attend the conferences that we're going to be at. That still isn't going to help the agencies at their own stations.
Well, since you throw that out there, just in case you're interested, the call for presentations for North Carolina closes this week.
Good to know. Thank you.
But I mean, and North Carolina is a great conference, and I say that kind of partially because I live here and I
Right.
spend a lot of time there. But getting stuff like that into conferences or into whether it's a state conference, a regional conference, or something else, is great. We've got a couple of regional conferences that have popped up here in North Carolina that are put on by a couple of colleagues, and they do a wonderful job.
Right.
And I think they want to expand it to do more hands-on and stuff like that. Start off with just a few presentations over a day and a half to 2 days, and it's starting to expand from there. So we've got to get the other part of that is we've got to get some of these people to conferences and to continuing education. And I used to say that continuing education should not be initial education rehashed. It should be picking up and moving forward.
Yeah.
But I'm afraid that for some of these COVID medics, we've got to really do some initial education
Yeah,
with
that's true.
continued education.
Mhm. Yeah, we've got to figure out what they don't know because they don't know what they don't know. They
Right.
might be able to tell us, I'm not comfortable in this, or this isn't my specialty, but I can muddle through it. And then there's things that are like, I had no idea.
And, I think some of the biggest places I see, of course, we talk about skills, but pharmacology,
Mm-hmm.
medication administration seem to be the biggest pieces that are lacking. And then, some of the other skills that, even we, that have been in EMS for a while don't do a lot of, such as, needle and surgical crikes.
Right.
And, maintaining chest tubes or A lines and other things like that, is not really been picked up in initial education.
Uh-huh. That's exactly right. And the high risk low incidence, that's a problem, COVID or non-COVID. Just haven't enough, or even our experienced medics to really feel comfortable with that.
Yeah, and as educators, we've got to look at that high risk, low frequency stuff, and then really start to aim some of our continuing education and aim some of our stuff at hitting those things as we get people in for a conference or a skills lab or stuff at work.
Mm-hmm.
We're very fortunate where I work that we have a fairly lengthy onboarding process. So if we bring somebody in, doesn't matter if they've been a paramedic for 30 years or 30 minutes. They start off at the same spot. Now we can apply their experience and stuff because they're going to move through stuff faster.
Mm-hmm.
But everybody's going to go through the same steps.
Okay.
You come in, you may be done in 15 days.
Mm-hmm.
Whereas it may take somebody else 8 months. So those are the
that's great. They set their pace, and in that 8 months, you can identify their weak points. You've got time to do that. That's great.
We hope it doesn't take that long, but
right.
but we've had some that it has.
Right.
But and that's been especially with some of the COVID medics that we're dealing with. Just because their comfort level is not there. Their patient exposure and acuity was not there in clinical or their field internships.
Uh-huh. Yeah, we keep on picking on the medics. I want to mention EMTs and nurses. COVID nurses, not too bad because, most nurses work clinics or inpatient. They're always going to be surrounded by other nurses. They're always going to have somebody to bounce things off of. EMTs, they've graduated their course. A lot of their stuff can be learned or can be practiced in the first several weeks of their work because it's basic stuff. And so they've got somebody there who can help them. Medics are on their own. Once you release them, they've got nobody else except their partner who may be an EMT, a good EMT. They might be a brand new EMT. They've got nobody out there to stop them from doing something that isn't right or isn't quite correct, or, just to kind of redirect them. So, we pick on the medics, but really they're the ones at the biggest disadvantage, in my opinion.
Yeah. And I think if we look at all of healthcare, it's those that have to or basically forced to operate independently, the ones that we really got to worry about.
Right.
So yes, nurses are typically around other nurses. You've got respiratory therapists, who are typically around other respiratory therapists, other providers who can, they can bounce things off of. But when you take an EMT, now they're going to pick up their skills a lot faster, like you said, because of the basic set of things that they can do. But there's a little bit of a gap there, and they're forced to operate independently. Paramedics, whether you're paramedic on a QRV or a paramedic working with an EMT, you're often forced to work and think independently. You're it. And it's frustrating to run into something and you don't know what you don't know.
Exactly.
And I can't stress the whole part of, a good assessment.
Mhm.
And I think we missed during all the COVID and even now, I don't know that educators are teaching how to do a good assessment and stressing the importance of a good assessment.
Mhm.
Um, the other day went out and was running calls and I was there first. And so the crew came in, I was working on the beginning of the assessment. And one of the first things I did was, the gentleman was having chest pain. And one of the first things I did is I kind of reached down, slid his sock down, and was touching his lower leg. And later the paramedic asked me, what were you doing? And I said, look, new onset of chest pain. This patient never really had a problem or cardiac event before. He is 60 years old. I was looking to see if he had hair follicles on the lower part of his leg. And he said, why? Did you think he shaved it or something? I'm like, no. If you've got, peripheral or vascular disease, the first thing you lose is hair follicles. I said, and peripheral vascular disease equals coronary artery disease. And he went, it was like a light bulb went on.
Exactly.
He said, I never thought of it that way.
Right.
He said, so afterwards he goes, okay, Obi-Wan, teach me more.
Uh-huh.
So we sat down and we had a very long afternoon of just going through assessments.
That's great.
But the whole part of that is I think we missed that with the COVID piece.
Yeah, for sure.
So when we look at a couple more notes here, I wanted to look at. So we've talked a little bit about the assessment. We've talked about skill acquisition. Let's talk a little bit, look a little bit more. What social health issues are we potentially dealing with our providers now?
Social health being their mental well-being.
Well, that and their interaction one with each other,
Okay.
with employers,
Mm-hmm.
or their supervisors, and their interaction with patients.
So, not COVID related at all, is the new generation of young adults who they've spent their high school years texting each other. There's no more passing notes in class. There's no more interaction. Everything's abbreviated, LOL, or if you know, YK, YK. There's a big social gap, but it's not COVID related. It's technology related. We're not forced to sit there and interact with people anymore. I was just at the airport yesterday, and instead of sitting there reading a book or sitting, talking to your neighbor, your seatmate, everyone was on their phone individually. So that is a huge gap socially, not COVID related at all. No one knows how to entertain themselves anymore. No one knows how to strike up a conversation. No one knows how to read social cues like, okay, this person isn't comfortable with this topic, or this person seems a little rushed. I may need to, close this conversation up. It doesn't exist anymore. The young adults don't know how to read that. I guess they don't know how to read a room, as some people would say. So socially, they're way behind, and that relates in our interpersonal relationships with our coworkers. At the stations 20 years ago, we were all sitting out in the day room, watching a TV show, playing a game, talking with each other. You don't get that anymore. You've got people on their phones in their recliners, or you've got them in their sleep rooms, not interacting. It's not a family environment anymore. So now you've lost that closeness. Like, I've just had a bad call. I need to go back to the station and just talk it out. That doesn't exist anymore. They get on their phones or they go to their rooms. And as far as interacting with patients, They don't know how, especially if you're a bit of a shy person or an introvert. It's not comfortable for you to go into somebody else's home and say, "Hi, my name is Janet. I'm here with this EMS company. What's wrong today? Tell me what's going on. How can we help you?" They don't know how to do that. They're kind of frozen, like, okay, I'm here, and the person's sitting there and their ABCs are intact. So now what do I do?
Yeah. So, I mean, I think the social and emotional intelligence
Mm-hmm.
it is not there.
No,
I think it was further compounded by COVID because we were forced to do more virtual stuff.
and we were
Yeah.
validated to do that.
Yeah.
Yeah.
So, but yes, before that, I mean, people are always on their phones, texting, everything else. And I don't know if I can pull it up, and I probably can't show it on here, but I was actually in the Detroit airport on Friday, and I thought, this is interesting. I'm sitting here looking around. I'm on my phone, and everybody around me is on their phone. So I just turned my camera on and basically took a video to show how many people were on their phones and unaware
Yeah.
of what was going on in the airport. People are no longer socially aware of their environment. I mean, have we lost the whole scene safe thing? Because I see EMS providers on the computer in front of the patient.
Mm-hmm.
I may take my computer in, but I try not to use it while I'm talking to the patient.
Right. Yeah.
So as educators, as employers, what can we do to identify, high risk groups such as, students with psychological burdens or unaddressed, concerns because of this lack of social and emotional intelligence?
As far as academically, there's always entrance exams, and we can kind of, give them a little bit of everything from NCCP, a little cardiology, a little airway, to see if didactically they've got it. As far as psychologically, you can get counselors in there. I know that one of the programs that I used to work for, they gave you a psychological entrance exam, and to take it, it didn't make sense. And they're like, just pick the answer that just resonates with you. And we did that, and it gave you a very accurate personality assessment. Now that's personality. As far as psychological problems, any hangups, anything like that, I feel like getting a counselor in there just to do like an entry level, session, find out where they're standing. What are your concerns? Are you excited about this job? Are you worried? What are some things that you're worried about? What's your home life like? That would be a great thing to have if you've got that resource, is have some type of a counselor or a peer who just is emotionally stable and can pick up on things. I keep on talking about Lori and my program. Lori is great about picking up on that. She's like, I'm sensing that they're not getting this. I'm sensing they've got some stuff going on, and that's why they're not acting, happy about this. That would be great if we could have that in every agency. It's not going to be practical, but it would thin it out. It would thin out those people that we're wanting to hire that maybe might not be a good fit. Not that they're not a good medic or EMT, but the personalities, every station is dynamic. Every shift is dynamic. A shift is different than B shift. And so maybe we had an opening in A shift, but their personality just may not match up with them. Let's do a little swapping. There's all kinds of ways to do it, but it requires time and money. And that's usually what we don't have enough of.
So one of the things that I always like to take some practical stuff away from our podcast and everything else. So what if we've got an agency representative or an administrator that's listening to our podcast, and they go, I know exactly what you guys are talking about. I've seen it. We have a COVID medic. We have a group of COVID medics. What's your advice to that agency administrator?
If they've just hired those COVID medics, they don't know anything about them yet. Get them together, help them as a group, have them identify themselves as a specific group. They are a subset. They are COVID medics. It's not a label. That's just an awareness to tell them, listen, we know you're at a disadvantage. We want to help you. You guys are together. We want you to rely on each other, and we need you to rely on us. Tell us what you know that you are weak in and that you want help with. And then as we move along, we are probably going to see things that you're weak in that you don't realize. We're going to help you get through this. They need that confidence boost. They need to know somebody's in their corner, and they need to be able to identify who else can I hang out with and to go to. And if they know this group is their group, it's going to help them. And of course, they're going to be working with the non-COVID medics and EMTs, and that's great. They're going to pretty quickly figure out which non-COVID medics are on their side, because not everyone is a good field supervisor. Not everyone is a good preceptor. So they're going to be drawn to those people who do have a little bit of compassion, a little bit more patience for their lack, and then encourage them to pick out those people that they do feel comfortable with and seek out that knowledge. If we're not doing enough skills with you, you tell us. We'll do more. What we thought was an adequate number of hours of skills practice, they may not feel that way for them. So I really want to instill confidence in them that you applied here to this agency and we would love to have you. We understand your perils. We're going to help you get through this.
Yeah. And before long, some of these COVID medics are going to be turning into preceptors.
Sure. Absolutely.
They're going to have paramedic students riding with them that, are learning different than they did. So, we've got to prepare them for that.
Exactly. And, war stories go a long way. No one's ever had a career that we just glided smoothly through life. We had those hangups. I always told my son when he went through basic training, the more it sucks during basic training, the better your stories are going to be when you get out. And so with COVID medics, it sucks when you first get out. And it's going to suck for the first, 6 months, year, 2 years that you're out. But when you finally get it and it clicks, then you've got those stories to tell. Like, hey, with your new person, I was a COVID medic and I struggled through this. I understand. And we're going to help you get through this. Even if they're not COVID medics, they've got that war story behind them that gives them that compassion that not everyone has.
So do you feel that there are specific studies or areas and skills that are lacking for that are probably common for all of them?
Critical thinking application and the skills, particularly the high risk skills, are the ones that we see that are very, very lacking. So, of course, I mentioned intubation. IVs, not so much. I don't know why. They tend to have pretty good practice with IVs, but assessments and critical thinking application and intubation for sure.
So you're talking about, in the future, hopefully you're going to have something that's going to hopefully be available for people. Don't want you to say too much about it, but
Okay.
But I want you to say, enough to kind of tease people to look for it.
Sure. Shameless spoiler alert, right? Shameless plug.
Right.
This would be a workshop of sorts. It might be 4 hours, it might be 8 hours, and it is designed for each class. So it's not going to be a specific agenda where we're going to do this. We're going to do a needs assessment on whoever hires us. It's probably going to be more conferences and refreshers than anything else to start with. But you tell us what your people are lacking. You tell us what we need. And for conferences, that's pretty general because they don't know all their participants. We'll send a poll out to the participants. You signed up for this class. You tell us, what would you like to see out of this class? Here's what we have to offer. What else would you like to see? And how much time would you like to spend on each of it? It's kind of a boot camp type thing. So it would be simulations, scenarios, skills, critical thinking application. If it's something as easy as I really struggled through getting through the concept of diabetes type 1 and type 2, we'll do that. we will get you through this. And, with it being such a short span of time, whether it's 4, 6, or 8 hours, that's not enough time. But at least maybe it will give them a little bit more confidence to where, like, okay, this wasn't too bad. This helps me from what I've done in the field so far. It's kind of putting the pieces together, and hopefully at the end of that boot camp workshop type thing, they'll go back and they will have that drive to go ahead and seek out more knowledge, reach out to those people who have the skills, practice, and say, listen, this is what I learned in this class. Let's expand on this. I want to do this here. Or can I show you what I learned in boot camp and see if that's the right way that we can do it here? And so it's going to be released in 2025, probably about mid 2025. I'm thinking May or June. Of course, marketing and getting that on the dockets for the conference may take another 6 months, but we're really excited about this, and can't see much more about it because I don't want to spoil it, and because it's still in our heads. We're still working out those hash points that we need to really focus on.
So, to throw this out there to you, just mine, but hands-on skills review,
Yes,
definitely would be beneficial.
Okay, sure.
Simulation and scenarios definitely would be beneficial. There again, when I say simulation and scenarios, of course, one of our previous episodes was with Joe Slattery, who is a simulation expert. They need to be validated.
Yeah.
So those, the simulations and scenarios have to be validated to make
Absolutely.
sure we're going down the right pathway.
Mhm.
Because unfortunately, during the whole COVID thing, when people were forced to do different things, sometimes we run students down the wrong rabbit hole in simulations.
Right.
We can't do that in these workshops. So I'm sure yours will be one of those that people will be looking forward to attending.
Thank you. That's what we're hoping. Definitely.
So we spent roughly about 45 minutes or 45 to 50 minutes now talking about transitioning that COVID paramedic into the real world and trying to work on correcting that knowledge gap and the skills gap. But really, while this has been a broad topic, it is something that each individual agency, each individual education institution has to do with their students, because your education style online is going to be different than mine.
Mhm.
So we have to find, where the students are and meet them where they are to fix that. Because if we don't do it in the next 4 to 6 years, we're going to find ourselves really in a crunch with some of these patients that we find, and people are going to be scratching their heads going, do paramedics really need to be doing this stuff?
Right.
If we're messing it up at an alarming rate.
Exactly. Yes.
So if somebody wanted to reach out and get in touch with you, what's the best way for them to get in touch with you?
My website is www.emsteacher.com. And they can also get a hold of me on my email, which is Janet Taylor, 6 at iCloud.com.
Okay. So any final thoughts on transitioning these medics to the real world?
It's not going to happen overnight. It's probably going to take another year or two to work out those kinks and get the newest of the COVID medics that would have graduated like 2020, 2021. They've been out in the real world for 2 years now. They probably figured out what they do and do not know. Our challenge is to identify what they don't know and what they don't know that they don't know, and get that worked out. Then we start working with the 2023 graduates and the 2024 graduates, and hopefully we'll catch up, and hopefully those online programs that have worked out the kinks, they are going to be graduating more medics and EMTs that do have a better grasp of this knowledge that the original COVID medics didn't.
Yeah, and one of the last things that I will put out there is I believe that the whole pandemic caused a lot of major physical psychological, educational, developmental, behavioral, and social and emotional intelligence, both short-term and long-term consequences.
Mm-hmm.
I don't think we have really seen the impact, nor will we see that impact for another, 5 to 6 years.
Exactly. Yeah.
And I urge every agency, every educational institution to evaluate where you are, to evaluate where your graduates are, and then to evaluate where your graduates that graduated 2 years ago are. Do you need to invite them back to sit down and say, hey, this is what we missed, so you can fix that?
That would be great. Yeah.
Because, if Ford Motor Company puts out a car and there's a problem with it down the road, they recall it.
Mm-hmm.
Sometimes we need to recall students to fix issues.
That's exactly right.
And, that says a lot about an educational institution or an agency, because, you recognize that there was a weakness and you fixed it.
Yeah.
So, but I would encourage, everybody out there to do that. If you guys want to, shoot us an email, you can reach myself or David Blevins. You can reach me at bradley.dean@handoffmedia.com, or you can reach David Blevins at david.blevins@handoffmedia.com. We want to thank everybody for joining us for another episode of the EMS Handoff with Janet Taylor. Janet, we want to say thank you for coming on and joining us. You have several other topics we may want to talk about in the future as well. So
thank you, David, for having me.
You're welcome. And one of the final things I want to say is I want to thank GEMS for hosting us on their platform and all the support that they give us as we post our podcast and push it out there. Look for David at FDIC. He will be there. I've got a couple other conferences and things coming up. We've got some stuff in March. Right now, it looks like we may be at EMS West at the EMS Update 2025, and a couple other places as we work throughout the next year. Again, thanks for joining us, and don't underestimate the value of your EMS handoff.